name's Amy. I'm one of the doctors at City Hospital. My lecture's on prescribing at the end of life, which is part of your palliative care learning outcomes. Prescribing at the end of life is important as it's the last thing you can do is to give somebody a dignified death. What we're going to cover is the symptoms that are associated with the dying phase. This will be pretty quick. To know what medications and what route is appropriate to relieve the symptoms that we'll discuss, to be able to prescribe these medications, and to understand how to titrate opioid medications, as I know from experience that came up in my MCQs. And just to finish, we'll identify when the need for a syringe driver is appropriate. So the symptoms of the dying phase, these are pain, agitation, secretions, breathlessness, nausea and vomiting. Pain is very common, particularly with bony metastasis, and other forms of cancer can be quite painful. Agitation is extremely common, particularly at the end of life with dementia. Secretions are common in the last 24 to 48 hours of life because the reflexes, such as the cough reflex, are very diminished. So you hear a wet sounding chest where there's just lots and lots of secretions in the upper airways that they simply can't bring up. Breathlessness often occurs more commonly with respiratory pathology, such as end-stage COPD or lung cancer, but can occur in any person who is in the dying phase. And then nausea and vomiting is also common. It's important to note that all patients have different symptoms, and some have a higher symptom burden than others. Some will have lots of pain and nothing else, whereas others will have breathlessness, for example. So every patient is different. Anticipatory medicines are the medicines that we give when somebody's in the dying phase. So the first thing to do is identify they're dying, and then you need to manage them appropriately. Morphine or fentanyl are both opioids, and these are given for pain relief in the dying phase, and they're often given as subcut injections. Morphine can be used only if the renal function is above 30, so if the eGFR is above 30. If this is less than 30, then we give fentanyl, and that's just because of the way that the drug is excreted and accumulates. Midazolam or haloperidol are the most commonly used drugs for agitation. There are other drugs that can be used. Midazolam is a benzo and haloperidol is an antipsychotic. You can't give haloperidol in Parkinson's disease. This will worsen their Parkinson's disease. So this just highlights how every patient is different, and you need to take into consideration the patient that you're treating. But this is just an overview of what's commonly used. Levopromazine is an antiemetic. It's more commonly used than any other antiemetic such as cyclizine or metoclopramide. The reason for this is that levopromazine is actually a very strong sedative agent. We use it at much lower doses to control nausea and vomiting, but if you are having a patient who is slightly agitated, then this will help alongside the midazolam. Hyoscine or glycopyrronium are used to reduce the secretions in the dying phase. This is an example of a prescription, well, a paper prescription. Most of us now have electronic prescriptions. So you would write the date, the drug, which you have to spell right, the route, so often this is subcut, and then the dose, the frequency, and the maximum dose. I don't think you would be expected to know the dose, the frequency, and the maximum dose off by heart. I think that would be a bit cruel. However, you should be aware of how you would prescribe them and roughly what their indications are, as this is what would most likely be asked of you. So the left is levopromazine prescription and the right is hyoscine. This is the same for morphine and midazolam. As you can see with the morphine, there isn't a maximum dose there because there is no limit to the morphine dose that you can give. And there's also a dose range for the medication. This is quite common. This is just a summary slide that you can take a photo of or print off if that's applicable to you. Just to have as reference. It's got the route, the maximum doses, and when you should consider a different drug, i.e. eGFR less than 30. Breakthrough pain is commonly used term in palliative care. So patients who are in the dying phase often already have a baseline opioid level, for example, Zomorph BD at maybe 30 or 40 milligrams BD. And then they'll be prescribed a PRN, so as required medication, such as Oromorph. Breakthrough pain is when the baseline pain relief is not enough and you require that PRN medication. A breakthrough pain medication dose should be a sixth of the total daily dose. This is what the palliative care guidelines and the BNF suggest. So if you are having 15 milligrams of Zomorph twice a day, so 30 milligrams, and you were requiring breakthrough pain, you would want 5 milligrams of Oromorph for their breakthrough pain. Breakthrough pain is a really good indicator of when you need to titrate their baseline medication, or if they're requiring a significant amount, that we might be heading towards the need for a syringe driver. To explain titrating medication, I'm going to use a case as I think it's easier that way. So we'll choose a 66-year-old gentleman, Mr. J, who unfortunately has terminal prostate cancer with bony metastasis. He's not confused, his GCS is 15, he's totally alert, and his oral intake and swallow is safe. In the last 24 hours, he's required his normal 60 milligrams of Zomorph BD, so twice a day, plus 6 lots of his breakthrough pain, which is a total of 30 milligrams of Oromorph. The first thing to note is that's not a significant dose to use as a breakthrough pain. The second thing is that he's required this for at least 3 days now. So first of all, we want to know exactly how much morphine he's had in 24 hours. So we know he's had his normal Zomorph and his breakthrough pain. This is a total of 150 milligrams in 24 hours. This means that we need to increase his Zomorph as it's been going on for a long time, at least 3 days now. So if you divide this total dose by 2, this gives you the amount of Zomorph that you should be giving. Now I've written that this has increased by less than 30%, which I'm not sure is accurate. It might be exactly 30%. But the reason I've written that in there is because guidelines state that you should only increase by up to 30% in one go, and if they're still requiring more, you will increase it sort of 3 days later, because there's this debate about shortening somebody's life rather than treating the pain, because morphine does suppress the breathing reflex as well, hence why we use it for breathlessness. So if his baseline is 150 milligrams in 24 hours, we should then calculate his breakthrough pain as 150 divided by 6, which is 25 milligrams of Oromorph. Obviously, he was having 5 milligram breakthrough pain before, so we should not increase it to 25 milligrams in practice, but the answer to this question would be 25 milligrams. This brings us on to the indications for a syringe driver. So the indications for a syringe driver are the inability to have oral medication. This isn't always because their GCS is low. It can be because they've got an unsafe swallow and they are towards the end of their life. It allows you to deliver continuously, so if you've got refractory or persistent symptoms, then this can be really useful, and sometimes patients actually request it, and I have had that on the geriatrics ward. A syringe driver is a large syringe that's put into a machine to deliver a certain amount of medication per hour. And this is a small butterfly needle that goes into the subcutaneous fat and is secured into place, and it's delivered into this compartment rather than into the veins, which often at the end of life collapse frequently, so you'd require frequent cannulation, which is painful for the patient and undignified. Back to the case, Mr. J has now got a GCS of 7. He's likely in the last 24 to 48 hours of his life. We want to make sure he's comfortable. He hasn't had his pain medication yesterday because of his reduced oral intake. And you think it's now appropriate to prescribe a syringe driver given that he's had lots of problems with his pain relief up until now. What are you going to prescribe in his syringe driver? Well, I haven't told you his renal function, so you'd want to know that first, but let's presume it's normal, so we would give him morphine. And I haven't told you in the case of any other symptoms, therefore it would be a morphine only syringe driver, but it is important to note that you can mix medications in syringe drivers. So you'd want to prescribe at least the 150 milligram zomorph equivalent. The reason I've written equivalent here is because 150 milligrams of PO, so oral morphine, is not the same as 150 milligrams of IV morphine. In fact, you'd be doubling his dose if you gave him that, and you would likely knock off his breathing, and in that case, you would be sued. So morphine, 150 milligrams, you need to divide that by 2. Some people give diamorphine, you have to divide that by 3. I don't think that the university would expect you to remember those figures, but it's just that you should be able to access the BNF if they need you to calculate these things. So for example, in an OSCE they might have a BNF. I have attached the conversion table next just for your interest. This is just a screenshot of the BNF. If you type in palliative medication or palliative care, then this conversion table comes up. Thank you for listening. There's also a conversion table for patches. I really don't think you'd need to know that, but maybe just be aware that if somebody has a reduced oral intake but they're not in the last sort of 3 to 4 days of their life, a patch might be more appropriate than a syringe driver. Thank you.